key genomic changes in gynecological cancer are quite complicated, and especially in ovarian cancer. Ovarian cancer has been researched most in gynecological cancer, and among the gynecological ovarian cancers, the high-grade serous ovarian cancer type is the most frequent and also best researched. The problem with this cancer is that it's a very complicated genetically cancer with a lot of genomic changes. As a matter of fact, most changes in the genome compared to all other tumors. We are not talking about mutations in high-grade serous ovarian cancer, but mainly about genetic losses or amplifications, what we call the genomic instability. And the genomic instability is very widespread in high-grade serous cancer. This makes it different from other cancers, like for instance lung cancer or colon cancer, where you have specific mutations which you can target. There is, however, one possibility, and this is what we call the BRCA or BRCA mutation, which makes the tumors, high-grade serous tumors specifically then, more sensitive for PARP inhibition. We believe, however, it's not specifically this BRCA mutation which is targeted, but the loss of all these genes. What we then now look for is loss of heterozygosity across the whole tumor. And in this way, these tumors have problems in repairing the DNA when there is a double strand break, which is done partly by, for instance, BRCA, but also by other mechanisms like PARP inhibition or with the help of the PARP enzyme. So when you inhibit the PARP enzyme and you have BRCA mutation, these cells are extremely sensitive for PARP inhibition, and these cancer cells die more quickly than the normal cells. So for high-grade serous ovarian cancer, one of the most interesting pathways, even though it's a genome-wide change, is PARP inhibition. In low-grade serous ovarian cancer, which is not so frequent, it's less than 5% of all ovarian cancers, we know that the RAS/MEK pathway is very important, and there are some interesting ongoing studies investigating this pathway with MEK inhibitors. And some studies combine this with PI3K inhibitors, for instance, MEK inhibitors with PI3K inhibitors, and these studies seem to be very interesting. The current status for targeted treatment has originally, the past 5 years, been dominated by angiogenesis inhibition in gynecological cancer, more specifically ovarian cancer. Of course, it started with the VEGF inhibitors, and then the first one was bevacizumab. In phase 3s, we have investigated other VEGF inhibitors, such as pazopanib, nintedanib, other tyrosine kinase inhibitors. We have seen that these VEGF inhibitors in ovarian cancer, also in endometrial and cervical cancer, but this has been studied to a lesser degree. But in the three most important gynecological cancers, we know that angiogenesis inhibition is important, and that we at least see an increase in progression-free survival overall. And in some subgroups in first line, also an increase in overall survival. For endometrial cancer, we think it's similar, but we don't have good phase 3 data. And for cervical cancer in recurrent setting, we know now that the addition of bevacizumab to chemotherapy increases not only PFS, but also OS and quality of life. We have also done in gynecological cancer a number of studies with other anti-angiogenesis drugs, mainly targeting angiopoietin and the type 1, type 2 receptor. In these studies, we have mainly used trebananib, which has been tested in the recurrent setting. And again, similar to the bevacizumab story, we see an increase in PFS, but not in OS in the recurrent setting. The first-line trial has been closed, and we are expecting the first results in mid next year. So that's the first part for anti-angiogenesis. The second part of targeted therapy, which has been used in ovarian cancer again, is the PARP inhibitors. It started first only in BRCA patients, where we saw an extremely good effect with low toxicity with PARP inhibitors. The first one was olaparib. Of course, later on, we have been testing other PARP inhibitors. The first tests, as I said, were in BRCA patients, as I explained before, because they are extremely sensitive for PARP inhibition. The next trials tried to combine PARP inhibitors with chemotherapy, but this was quite difficult because PARP inhibitors induce bone marrow toxicity, and especially in platinum-sensitive ovarian cancer, where we use, for instance, a combination chemotherapy with carboplatin, it was difficult to combine. So the first pivotal trial was done in platinum-sensitive patients who received platinum-based chemotherapy, and if they responded, they were randomized to olaparib or placebo. And these results were astonishing, with a hazard ratio in BRCA patients which was below 0.15, which is extremely well and not ever seen in ovarian cancer. I said this is for BRCA patients. We tested also other patients with high-grade serous tumors. Also there we saw an effect which was a little bit less, but still highly significant. So that started the search why these patients, despite the fact they do not have a BRCA mutation, respond to PARP inhibition. And as I explained earlier, this is mainly to major losses and in other places of the genome, amplifications, copy number variations in these high-grade serous tumors, making them sensitive for PARP inhibition. There are also other mutations than BRCA, but they play only a minor role when you look on the frequency, like RAD51C and D, for instance. So they are probably also important, but their incidence is not so high. What is more important is the other group of high-grade serous ovarian cancers, which are not based on BRCA mutation, which can be in germline or somatic. We believe now that about 2/3 of the high-grade serous ovarian cancer patients respond to or will respond to PARP inhibition, and there are now several new trials which try to identify what we call the BRCA group and the BRCA-like group. No BRCA mutation, no RAD51 check or ATM and so on mutations, but still sensitive to PARP inhibition. The biomarker research in ovarian cancer is challenging, especially in high-grade serous ovarian cancer, but we have interesting pathways, for instance in low-grade serous tumors with the RAS MAP pathway, in clear cell and endometrioid tumors with the PI3K pathway, in all tumors with p53 mutations like high-grade serous, and some endometrium and clear cell tumors with p53 modulation. So these are the main areas of research in gynecological cancer currently. For cervical cancer, which is almost always caused by HPV infection, we have some tests with therapeutic HPV vaccines, whether they are, for instance, HPV-16 positive or not, if the vaccine is against HPV-16. There are also newer data using, for instance, HPV T cells or T cells targeted against HPV as well, which have been recently reported. The molecular tumor profiling has been difficult in ovarian cancer because the main type is not driven by one mutation, not even subgroups of mutations, namely the high-grade serous ovarian tumors. So therefore tumor profiling has been much less important currently than in other tumours in gynecological cancer. But we will come there because in small subgroups I'm convinced that we will have molecular profiling as an important tool, like again prediction of MEK sensitivity in low-grade serous tumours, PI3K in some endometrioid clear cell tumours. The access to targeted therapy in gynecological cancers has been limited, except then for the anti-angiogenesis drugs, and soon the PARP inhibitors in Europe. Outside that, it has been difficult because one, gynecological cancers are not frequent, making research difficult from our side, the academic side, but also for the industry in a subgroup of an infrequent tumour. We don't have good biomarkers, except for very rare subtypes of ovarian and endometrial cancer. In the future, we will do also phase 3 trials in better defined subgroups of ovarian, endometrium, and probably also cervical cancer. We will have to cooperate globally to do these studies, and we have started this type of projects. And this will be the only way forward. We can't just start new trials without first identifying the biomarker.